This recorded lecture will go over Chapter 13, Drugs for Inflammation, Arthritis, and Gout, in the Introduction to Clinical Pharmacology textbook. Inflammation is a response to injury or infection caused by white blood cells and their products that result in reactions of tissues and blood vessels. These reactions will cause 5 major symptoms of inflammation: pain, redness, warmth, swelling, and loss of function. When inflammation occurs over a long period or occurs without tissue injury or invasion by bacteria and other organisms, the result is an overreaction that can damage or destroy tissues. When an injury occurs, the damaged tissues and white blood cells in the injured area will release inflammatory chemical mediators. These will cause important actions to occur. These chemical mediators are important in starting and continuing inflammation. They include kinins, prostaglandins, histamine, and tumor necrosis factor. As more white blood cells come to the injured area to fight possible pathogens, the inflammatory response is increased by the arachidonic acid cascade. The enzyme cycloogenase, or COX, will then convert AA into many mediators, especially different types of prostaglandins. COX-1 in the cells of the stomach lining will make prostaglandins that produce a thick mucus. This mucus actually protects the stomach lining from being harmed by gastric acids needed for food digestion. COX-2 is present mainly in areas of inflammation. COX-2 is responsible for the types of prostaglandins and other mediators that start and continue the inflammation response. You can think of COX-2 as the bad COX. White blood cells release growth factors that trigger repair of damaged tissues and cells, stimulate healthy cells in the injured area to divide and replace dead or damaged cells, and promote scar tissue formation in tissues that can no longer divide. Remember that scar tissue will not act or function like normal tissue does. Many acute problems that cause inflammation, such as sprains, fractures, or tears, require short-term therapy with anti-inflammatory drugs. An anti-inflammatory drug has a primary purpose to reduce pain and to prevent or limit tissue and blood vessel responses to injury or invasion. Long-term therapy is prescribed to reduce the symptoms of inflammation and prevent tissue-damaging complications. It is important to recognize that most of the drugs used to treat short-term or long-term inflammation can have serious adverse reactions. The patient's response to therapy must be monitored very closely. When inflammation is managed, pain can also be relieved to some degree, which is why anti-inflammatory drugs are prescribed for pain management. A nonsteroidal anti-inflammatory drug, or NSAID, will slow the production of one or more inflammatory mediators, therefore preventing or limiting tissue and blood vessel responses to injury. NSAIDs are divided into 2 categories: non-selective NSAIDs that inhibit the actions of COX-1 and COX-2, and selective NSAIDs that have more inhibitory effects on the COX-2 enzyme and lesser effects on the COX-1. Non-selective COX inhibitors, such as aspirin, ibuprofen, and other NSAIDs, will disrupt COX-1 and COX-2 enzymes. Non-specific NSAIDs have more side effects than selective COX-2 inhibitor NSAIDs. Selective and non-selective NSAIDs have the same anti-inflammatory actions. They both reduce the production of prostaglandins, kinins, histamine, tumor necrosis factor, and other inflammatory mediators that are derived from AA. The oldest NSAID still in use today is aspirin, which has a salicylate chemical structure. NSAIDs are typically the first drugs used to treat a variety of inflammation-based problems that are often associated with pain and fever. Pain in the muscles, nerves, and joints, headache, and dysmenorrhea are commonly treated with NSAIDs. Non-selective NSAIDs, particularly aspirin, can inhibit platelet aggregation. The effect on platelets can also lead to an increased risk of bleeding, particularly when NSAIDs are given at higher doses. This is very important if a patient is scheduled for an invasive dental or surgical procedure. The healthcare provider must be aware of the situation so that the aspirin or NSAID can be discontinued 1 week before the procedure. Common side effects of non-selective NSAIDs include heartburn, nausea, vomiting, dizziness, headache, and increased risk of bleeding or bruising. The GI effects can be minimized or avoided if this drug is taken with at least a full glass of water. All NSAIDs except aspirin will cause some degree of fluid retention, edema formation, and increased blood pressure. Adverse reactions must be recognized and reported to the healthcare provider immediately, and the drug will most likely be discontinued. Several adverse reactions can occur in patients taking NSAIDs, including allergy, renal failure, upper or lower GI bleeding, and blood disorders. Patients who are allergic to one non-aspirin NSAID may also be allergic to another due to cross-sensitivity. This is generally rare, but it is important to note all allergies within the medical record and, of course, report them to the healthcare provider prior to administering the drug. Aspirin has been associated with the occurrence of Reye syndrome when given to children with a viral infection, like varicella or influenza. Therefore, the use of aspirin is avoided in children, especially when those with an acute illness. On page 241, see the lifespan considerations for pediatric patients. Aspirin should not be given to infants or children who have an acute illness due to its association with the development of Reye syndrome. This disorder can lead to mental deficits, coma, or death. Too much aspirin can lead to toxicity and can be life-threatening. Symptoms of aspirin toxicity can progress from mild to severe. Beginning with tinnitus, hyperventilation, diaphoresis, thirst, headache, drowsiness, skin eruptions, and electrolyte imbalance. Symptoms can then progress to CNS depression, stupor, convulsions, and coma, tachycardia, and respiratory insufficiency. On page 241, see the green lifespan considerations box for older adults. Older adults taking NSAIDs have a higher incidence of excessive bleeding and perforated ulcers compared to younger adults. Older adult patients who have some degree of renal impairment are at a higher risk of damage to the liver and kidneys caused by NSAIDs. These drugs should be avoided in older adults. If they are prescribed, they should be administered with a proton pump inhibitor, like Prilosec, to reduce any risks of GI effects. Alcohol taken with any of the NSAIDs will increase the risk of GI bleeding. NSAIDs interact with each other, which increases the risk of side effects, adverse reactions, and toxicities. Patients should not be taking more than one type of NSAID at any one time. Here are some examples of common interactions. Aspirin and other NSAIDs should not be given to treat vaccination-associated fever and pain because they can prevent a normal immune response and its protection. NSAIDs, except for aspirin, will decrease the effectiveness of many antihypertensive drugs, especially ACE inhibitors, ARBs, beta blockers, and most diuretics. All NSAIDs will increase the risk of bleeding for patients taking any type of anticoagulant. All NSAIDs will increase the risk of hypoglycemia in patients with diabetes taking oral anti-diabetic drugs. Ask your patients whether they are using any over-the-counter or prescribed NSAIDs, because patients will sometimes not report them, or many will actually forget the occasional use of aspirin or another over-the-counter NSAID. The dosages for different NSAIDs can vary widely. There are many forms of NSAIDs, including tablets, capsules, eye drops, chewable preparations, suppositories, and injectables. Several NSAIDs can be applied topically. Give the NSAID with a full glass of water to reduce the risk of GI disturbances. If the patient has stomach upset, try giving the drug with food or milk to reduce symptoms. The patient should be well hydrated before taking a drug to reduce the risk of kidney damage. Monitor your patient to be sure that the symptoms resolve. Reduction of inflammation can take as much as 1 to 2 weeks in some cases. Assess your patient for signs of increased bleeding, especially in the gums and mucous membranes. Examine their stool, urine, and vomitus for blood. When blood counts are performed, assess whether the numbers of red blood cells and platelets are normal or low. Report any low counts to the healthcare provider immediately. Teach your patient and family the following. These drugs can cause stomach upset. All NSAIDs should be taken with a full glass of water and food. Contact your healthcare provider right away if ringing in the ears, abnormal bleeding or bruising, or bloody black tarry stools are noted. Go to the emergency department immediately if you experience chest pain, shortness of breath, or other signs of a heart attack. For some chronic problems, you may need to take a prescribed NSAID for longer than 1 to 2 weeks before noticing a decrease in symptoms. You should drink at least 8 to 10 glasses of water per day to stay well hydrated while taking an NSAID. For best effect to reduce inflammation, take the prescribed NSAID on a regular schedule to keep a stable blood level of the drug. Do not take any other drugs, including over-the-counter drugs, at the same time as this drug without telling your healthcare provider. Contact your healthcare provider if a fever does not come down within 24 to 48 hours. Keep aspirin and all other NSAIDs out of the reach of children. If you are unable to take the drug in the form prescribed, contact your healthcare provider so another form of the drug can be used. Corticosteroids are also known as glucocorticoids. These are drugs built on the structure of cholesterol that can prevent or limit inflammation by slowing or stopping the pathways of inflammatory cytokine production. These drugs can be given to replace missing or low hormone levels in cases of adrenal insufficiency. They are most commonly used, however, to reduce the inflammatory response. Common systemic corticosteroid drugs include prednisone, methylprednisolone, hydrocortisone, and dexamethasone. Corticosteroids are useful for managing severe or chronic inflammation. They will also slow the production of white blood cells in the bone marrow. The actions of corticosteroids will occur in all cells, not just the ones involved in inflammation. As a result of this, their therapeutic effects, side effects, and adverse effects will be widespread. These problems can limit how and when they are used. Corticosteroids are most commonly given to reduce inflammatory, allergic, or immunologic responses. Corticosteroids can be injected locally for problems related to joints, soft tissues, or bursa. Topical corticosteroids can be prescribed for acute or chronic dermatoses, rectal problems, and some eye or ear problems. Inhaled corticosteroids are commonly used to manage inflammation associated with asthma. Common side effects of corticosteroids that can occur even when they're used for relatively short periods of time would include sodium retention, increased blood pressure, weight gain, bruising, and reduced immunity. It is not unusual for patients, particularly diabetics, to have an elevated blood sugar level, and doses of insulin or an oral hypoglycemic agent may need to be adjusted while the patient is receiving steroid therapy. You should monitor their blood glucose regularly. These drugs also especially increase the risk of bleeding in general and especially in the GI tract. On page 244 in figure 13.3, you can see the physical changes associated with long-term corticosteroid use. This is known as Cushing syndrome. These changes can reverse after the patient stops taking the drug, but reversal could take several months to a year. Many effects of systemic corticosteroids can cause serious problems if not managed carefully. These issues are not problematic for topical corticosteroids. The most important problems are associated with long-term use and include adrenal gland suppression and reduced immunity. Adrenal suppression occurs when circulating blood levels of corticosteroids are higher than the amount of cortisol normally made by the adrenal glands. Because cortisol is necessary to maintain life, the patient who suddenly stops taking systemic corticosteroids has no circulating cortisol, and they could die from acute adrenal insufficiency. Symptoms include anorexia, nausea, vomiting, lethargy, headache, fever, joint pain, skin peeling, myalgia, weight loss, and hypotension. Patients who have been taking any corticosteroid daily for 1 week or longer need to slowly decrease the dose over time. This is known as tapering, rather than just stopping the drug suddenly. Tapering of the drug will allow the atrophied adrenal gland cells to gradually begin producing cortisol again and will prevent acute adrenal insufficiency. Any use of corticosteroids will also reduce the number of white blood cells. This can decrease inflammation, but also decreases the immune response. The longer the patient has been taking a corticosteroid and the higher the dose, the more immunity will be reduced. This greatly increases a patient's risk of infection. It is especially important to monitor patients for other signs of infection, including cough, changes in color of sputum or other drainage, and symptoms such as headache or behavior changes. Other adverse effects associated with long-term corticosteroid use include osteoporosis, cataract, hypertension, and ocular hemorrhage. Corticosteroids increase the effects of barbiturates, sedatives, narcotics, and anticoagulants. They decrease the effects of insulin and oral hypoglycemics, isoniazid, and broad-spectrum antibiotics. Drugs that increase the effects of corticosteroids include other NSAIDs and oral contraceptives, especially estrogen. Because NSAIDs can cause GI distress, the use of aspirin or any other drug should be avoided while taking corticosteroids. There are many contraindications to and precautions for the use of corticosteroids, and it is important to obtain an accurate drug history, including over-the-counter drugs, herbal agents, and any topical or inhaled drugs. The most important contraindication for corticosteroids is the presence of infection, because corticosteroids will increase the risk of a more severe infection. Steroids tend to thin the skin, and their use increases the risk of skin tears. Steroids can also slow wound healing, and therefore should be carefully assessed in patients having any type of surgery. Corticosteroids can be administered by the following routes: oral, inhalation, intranasal, IV, IM, subcutaneous, intrabursal, intradermal, intrasynovial, intralesional, soft tissue injection, topical using creams or gels, with ophthalmic and otic preparations, and per rectum. Topical steroids should not be applied to open wounds. Topical steroids should be avoided if there are any signs of infection, because they may increase the risk of spreading the infection due to their effect on the immune and inflammatory response. Corticosteroid dosages will vary, and the dose is determined for each patient based on the specific problem or diagnosis, their severity, prognosis, and estimated length of treatment. The general rule for prescribing corticosteroids is to prescribe as high a dose as necessary initially to get a favorable response, and then to decrease the amount gradually to the lowest level that can maintain therapeutic effect but not produce complications. Do not exchange one type of systemic corticosteroid for another, because the dosages may not be equivalent. It is recommended that doses of oral corticosteroids be taken with meals or a light snack to help reduce the chance of any GI distress or peptic ulcer. Oral corticosteroids are almost completely absorbed within the GI tract. For corticosteroid injections into a muscle or joint, it can take several days to weeks for the onset of effects. When corticosteroids are given orally to patients with functioning adrenal glands, the total dose should be taken first thing in the morning. Patients who require high-dose or long-term treatment should be monitored carefully for up to 1 year after the drug is stopped for any symptoms of adrenal insufficiency. Corticosteroids can hide the usual symptoms of infection, and they also increase a patient's risk of infection. This makes it essential for you to monitor the patient for any unusual symptoms that could suggest infection. Corticosteroids are particularly dangerous to use in patients with a history of TB because the disease can be reactivated. It is important to monitor for any cough or shortness of breath in these patients. Teach your patient and family the following. Keep all appointments to monitor therapy whenever taking this drug. Heavy smoking can add to the expected action of a corticosteroid because nicotine will raise the blood level of naturally secreted cortisol. Avoid alcohol. Report any signs of infection. Inform other healthcare providers that a corticosteroid is being taken. Report any of the following signs and symptoms to the healthcare provider immediately because they indicate a life-threatening problem of adrenal glands: malaise, weakness, hypotension, anorexia, nausea and vomiting, aching of bones and muscles, headache, increased temperature, and diarrhea. Do not stop taking the steroids suddenly. During and after corticosteroid treatment, you should wear a medical alert bracelet or necklace and carry a medical identification card with the name of the drug. Do not receive any immunizations without consulting the nurse or other healthcare provider first. Take oral corticosteroids with a meal or light snack to minimize stomach upset. Eat a diet that is rich in potassium and low in sodium to replace lost potassium and prevent any excessive water retention. If you forget to take a prescribed dose, take the next dose as soon as possible and then follow your prescribed schedule. Call the nurse or other healthcare provider if any of the following develop: rapid weight gain, black or tarry stools, unusual bruising or bleeding, or signs of hypokalemia, including anorexia, lethargy, confusion, nausea, and muscle weakness. A disease-modifying antirheumatic drug, or DMARD, will reduce the progression and tissue destruction of the anti-inflammatory disease process, especially within rheumatoid arthritis, by inhibiting the tumor necrosis factor. DMARDs are prescribed primarily by specialists to prevent or limit bone destruction, and they are used only in diagnosed cases of rheumatoid arthritis or another chronic inflammatory disorder that has been getting worse despite any other types of treatment. Patients taking these drugs need constant follow-up and regular evaluation, and they may be admitted to the hospital or seen in the office for other problems. The most commonly used DMARDs will inhibit the inflammatory mediator TNF. This prevents cells within the TNF receptors from continuing to produce more TNF and other substances that enhance the inflammatory response and cause direct tissue destruction. As a result, pain is relieved, physical function improves, and tissue damage is reduced or delayed. Most DMARDs are given by injection, although there are a few oral formulations as well. The two most common DMARDs are adalimumab and etanercept. DMARDs are used to treat many types of chronic inflammatory disorders that involve severe tissue destruction caused by excessive amounts of TNF. In addition to rheumatoid arthritis, other autoimmune disorders that respond to DMARDs include ankylosing spondylitis, psoriasis, psoriatic arthritis, Crohn's disease, and ulcerative colitis. The most common side effect from injected DMARDs is a reaction at the injection site. Reactions would include pain, swelling, itching, and redness at the site for about 1 week. Severe adverse reactions are possible and relatively common in patients taking DMARDs. All DMARDs reduce the patient's immune response to some degree, increasing their risk of infection. Although reduced immunity is an expected result of therapy with DMARDs, it is considered an adverse reaction that must be monitored for severity. If reduced immunity is severe enough or a severe infection develops, the DMARD therapy will be stopped. DMARDs can cause heart failure that may be new or more severe while taking the drug. Patients taking injectable DMARDs may be at a greater risk of allergic reaction, even anaphylaxis, because these solutions can contain some animal proteins. If the patient is taking any other type of drug that reduces immunity, taking a DMARD will make immunosuppression more severe, greatly increasing the risk of infection. Some immunizations contain live vaccines. For patients receiving DMARDs, live vaccine immunizations are avoided because the patient could develop the disease the immunization is intended to prevent. Before giving a DMARD, ask the patient to list every drug that they are currently taking. Ask about any symptoms of infection, including fever, cough, foul-smelling drainage, pain or burning upon urination, and general malaise, as well as any recent exposure to people who are ill. All patients should be tested for tuberculosis prior to starting a DMARD. The first dose of an injectable DMARD should be given by a physician or registered nurse in a setting that can handle severe allergic reactions. It cannot be started in an extended care facility or at home. Keep an emergency cart close to the patient during the first injection and for 2 hours afterwards. Observe the patient every 15 minutes for any type of allergic or adverse reaction for at least 2 hours. These observations will include respiratory rate, ease of respirations, blood pressure, pulse oximetry, and rash or hives at the injection site. After the first therapeutic dose is given and no adverse reactions have occurred, LPNs can administer subsequent doses. Carefully read the specific directions for administration of drugs prior to giving them. Closely monitor the injection site and the whole patient for any signs of an adverse reaction. Document the patient's response even if no problems occur. Teach your patient and family the following. Check for and report signs and symptoms of infection. Teach patients how to inject themselves and obtain a return demonstration of the proper technique prior to discharge. Report any nausea, vomiting, loss of appetite, severe fatigue, or changes in color of the urine because these could be symptoms of problems with the liver. Do not take any over-the-counter drugs without contacting your healthcare provider to avoid any dangerous drug interactions. Gout is a metabolic disorder that causes a person to produce or accumulate too much uric acid crystals from the proteins they eat or to not eliminate the crystals in the urine. These crystals are then deposited in joints, tendons, and surrounding tissue, causing the arthritis symptoms of pain, redness, and swelling, as well as progressive joint damage with loss of function. Although the metabolic disorder is always present, the symptoms of gout can come and go. About 10% of people who have gout can control their problem through lifestyle changes, involving eating less of the foods that produce uric acid, including shellfish, herring, sardines, salmon, haddock, and anchovies, red meat or organ meats, and pork, beer and wine, and any drinks made with high fructose corn syrup. Losing weight, if obese, avoiding alcohol, and including low-fat dairy products and complex carbohydrates in the diet can reduce the risk of flare-ups. When patients have symptoms of gout, general anti-inflammatory drugs will help reduce the pain and inflammation, but they do not address the uric acid problem. These drugs will also not prevent progressive joint damage. Drugs that lower uric acid levels can prevent gout attacks and reduce symptoms during an attack. The most common drugs used to reduce the uric acid levels associated with gout include uric acid synthase inhibitors. The two drugs in this class are allopurinol and febuxostat. Allopurinol and febuxostat help prevent gout attacks by reducing the amount of an enzyme that converts purines into uric acid. These drugs help patients maintain a lower blood uric acid level. The main use of anti-gout drugs is to prevent gout and shorten gout attacks. For gout prevention, they also must be taken daily. The most common side effects of allopurinol and febuxostat are headache, rash, and minor nausea. Teach patients to report increased gout symptoms. Gout flare-ups can be managed with NSAIDs or colchicine. Adverse reactions to allopurinol and febuxostat are rare, and they occur only with very long-term use. They include kidney stone formation, liver failure, heart failure, and stroke. Rarely, depression and cardiac dysrhythmias have been reported. Aluminum-based antacids will inhibit the absorption of allopurinol. Anti-gout drugs will also interfere with the metabolism and action of warfarin. Patients are rarely hospitalized for gout. The most important action is to teach patients how to take these drugs to prevent and control gout. Teach your patient and family the following. Take allopurinol after a full meal. Drink 8 to 16 glasses of liquids, especially water, throughout a 24-hour day period. Wait at least 3 hours to take allopurinol after using an aluminum-based antacid. Febuxostat can be taken with or without meals and is not affected by antacids. If you are breastfeeding, do not take these drugs. Avoid foods that are high in purines because those foods can precipitate an acute attack. Keep all appointments for lab tests of uric acid levels and for kidney and liver function tests while taking these drugs. Many drugs can trigger gouty flare-ups, and it's important to let your provider know that you do have gout.